Our next presenter on the same topic is Leavitt. He is the medical director at the Waisman Center on Human Development and professor of pediatrics at the University of Wisconsin-Madison.
Thank you. It's a pleasure to come after having, as an investigator, received such encomium from John Lantos, hyperbolic or not. For those of us who care about justice, beneficence, autonomy, I think we need to consider that in discussing informed consent, we ought to pay attention to those who might be most vulnerable to problems. That is to say, when we want to understand a society, its justice, the nature of its values of distributive justice, we ought to be looking at those who are most diminished, who are vulnerable to problems. And that's what I will concentrate on today. If I may have some advice from... there. You have to know where to point. I'm going to hit some high points, obviously, which should be underlined rather than give a very extensive disquisition given time, and I hope to leave a good deal of time for discussion. Informed consent is an ideal, it's a goal. There are barriers to achieving this goal that are present in the population at large, as we've heard already, and there are subpopulations who are particularly vulnerable to misunderstanding and not fully involved in voluntary participation. As we've heard, informed consent is a dynamic process. Investigators must carefully consider risks and benefits of the proposed research, but more importantly, they have to formulate this information with clarity, concision, and match the level of discourse appropriate to the patient or subject population. And then there's this other part where research subjects are asked to process this information, ask questions, make decisions, and there are elements of vulnerability for special populations within those two parts of the dynamic. As well, informed consent historically and pragmatically doesn't only serve to promote beneficence and respect for subject autonomy. The process of informed consent demands that investigators carefully and openly consider foreseeable risks and barriers, and thereby the process provides an extra barrier to unintended mischief. So the part where the investigator must mull over what are the implications of this research, I think is an important part, whether or not it is placed in written form. Standard of care research, others have said that, is research. The elements of informed consent should not be compromised by assuming that the subjects are knowledgeable about the risks and options of this quote-unquote standard care. And we've heard already about questionnaires and surveys that show a substantial number of patients are not really aware of some of the implications of risk associated with their therapy. Also, we have to keep in mind, as we think of the broader issues of standard of care, that there are populations in the US, and particularly internationally, after all, a lot of research by US researchers is done internationally. And there are these populations for whom, and it's true in the United States as well, for whom so-called standard of care is an aspiration. It's not every day. Comparing one drug to another or one intervention to another may, in particular contexts, not meet the requirements of equipoise, and we ought to be aware of that. There is as well the tyranny of the written form. The written form with the subject's signature of consent is a proxy for informed consent. We've heard a lot about this already. It's a token for the process of informed consent. And too much emphasis has been placed on the written medium for education and information. The informed consent form should not be conflated with what we mean by informed consent. We've already heard a very fine presentation that summarizes work that show that in all sorts of studies, from surgical to medical, frequently only a minority of patients who are exposed to the written form of information and consent really understand the process of randomization, the nature of volunteering, and importantly, the risks of the study. So this research has shown that the written form is a modestly effective educational instrument, and that the solution is not longer and longer forms. Also, when the written form is emphasized as the prime medium of information transmission, it by itself creates particular populations who may be more vulnerable to misunderstanding and coercion. These are populations who, for a variety of reasons, are not adept at understanding information presented in that way. Those vulnerable populations are indexed by a number of variables, but they include power differential, cognition, and the potential for coercion. And you all know these populations. I'll go over them quickly. Certainly children, and of course we use surrogates in some of these populations, individuals with cognitive disability, people with low literacy, non-English speakers, hospitalized patients who may feel that participating or not participating could get their caregivers angry or give them care of a different sort. Patients who are too ill to understand or consent. Emergency situations where initiating therapy immediately is very important. And we need to consider how we might use surrogates or provide information later. Cultural, religious, ethnic minorities, Professor Gamble had already brought this up earlier, but certainly these are vulnerable populations. The medically uninsured and impoverished people, for whom, again, standard of care is an aspiration, and of course, prisoners. I'd like you to think a minute about the parable of the 4 children at the Seder. Actually, there's some wisdom in a very old process. In the Seder is a ritual in which certain kind of information is imparted, and there's a tradition of thinking of the recipients, that is to say the next generation children, as being divided into subgroups. The wise one who understands when informed, the one who doesn't want to listen, the one who doesn't quite understand, and the one who doesn't even know how to ask. My point is, we tend to aim for the wise one. We need to attend more intently to the other 3. Now, the elements of understanding include comprehending relevant information, language complexity, technical terms. We need to understand that when we use the written form, or even the oral form, that a term such as risk may have, or randomization, may have a technical definition, but it also has vernacular definitions, vernacular use, which may differ by subpopulations, and we need to consider that. I think Dr. Lantos has very well divided some of the, or identified the elements of understanding, but certainly it includes medical condition, what is randomization, what is risk with or without enrolling, the volunteering, the nature of possible coercion, and options when not volunteering. So the barriers to understanding include understanding this information about the likelihood of risk, mistrust of research, the status of guinea pighood may have a very different valence for very different subpopulations, and of course, the fear of consequences of not cooperating with providers of much needed services. Concepts of probability are not well understood by many adults. Some of my earliest publications were writing math textbooks for children, and teaching probability is very difficult. And I am very enthused about some of the research we've heard about earlier today and yesterday that seeks to impart concepts in a concise, clear manner, not necessarily using the written form. So it's important to ensure that risk estimates are expressed at the appropriate level of discourse, and that might take some back and forth. We need to keep in mind when we identify risks and or benefits that they may have a higher or lower valence for specific populations. One example is that even a very low risk of loss of fertility or impotence may weigh very heavily with some subjects' decision-making. So there are some special areas of concern. We've heard a lot of talk about randomization, but there's also the issue of the patient's assumption that their care is individualized. What does that mean? Explaining the voluntariness of participation, and explaining that non-participation will not jeopardize care. This doesn't have to take a long time, but I think it's important to make sure that subjects have some understanding of this. The bottom line is that we need a lot more research on techniques of achieving more fully understood informed consent, especially with populations who are vulnerable. This could include the use of multimedia, visual and auditory storytelling, a multi-part process when it's feasible, and of course, with the written form, the use of plain language, short sentence, non-technical vocabulary, and very importantly, the use of concrete and not abstract language. So we need to realize that, and I'll emphasize this again, that fully informed consent is an ideal, that the written form does not need to be book length, and in fact, by emphasizing written forms alone, we may be doing a disservice to many of the people who are potential subjects. Thank you.
Any questions, comments? I think there's one.
Yes, I just had one question, one point you made that I may not have followed. I think you said that vulnerable populations, that may interfere with the construct of equipoise. And I could certainly see how vulnerability might affect voluntariness, but I'm not sure about how it would affect equipoise.
Just use the mic.
Yeah, the example I gave was international work where standard of care may be such that in terms of availability, say, give an example of drugs, of monitoring drugs in a certain way or monitoring patients where there may actually be an advantage of one drug over another that would not be the case if it were done in Europe or the United States. And therefore, in translating important but similar research to places where hospitals or clinics are wanting, the equipoise that we seek for drug A and B would not hold. Does that answer your question?